We are live.
Good evening, all. We are back on the online portal of iFocus Online. After 1 week of PowerPad lectures and a very successful iFocus event, we are here happy to host you all on the lecture 285, the 26th in the UVA module, by Dr. Vijay Pratap Singh Tomar, sir, from Regional Institute of Ophthalmology, Sitapur. He shall be speaking to us on white dot syndromes, which is a quintessential topic and very much neglected among the postgraduate students. May I now request Dr. Dipankar Das, sir, to please introduce the speaker for today.
Thank you, Dr. Subhab. Greetings to everyone on the occasion of Holi. It's my proud privilege to introduce Dr. Vijay Pratap Singh Tomar. He did his diploma in ophthalmology from Rio Ranchi in 2007, and he did his master's in ophthalmology from RIO Ranchi in 2010. He did his fellowship in UV and medical retina from prestigious Shankar Netralaya, Chennai in 2010 to 2012. He was a senior consultant in UVA and medical retina service presently at Sitapur Eye Hospital since 2013. Currently, he is a professor in Regional Institute of Ophthalmology, Sitapur. He is a resource teacher of uveitis in AIOS academic and research PG teaching course, and is a journal representative of Uveitis Society of India. He will be speaking on spectrum of white dot syndrome tonight. Over to Professor Vijay.
Thank you so much, sir, for your kind introduction. And I'm really very much thankful to Team iFocus, especially Dr. Santosh Honava, sir, who has given me this opportunity to interact with the brightest mind of ophthalmology, that is our postgraduate residents. And while discussing this white dot syndromes, I have tried my best to make this very simple, discussing just salient features of the white dot syndromes. So as we all know that white dot syndrome is a group of disorder which is characterized by the presence of whitish lesion in the choroid, retinal pigment epithelium, and involving neurosensory retina. So there is a long list of all these syndromes comprising acute posterior multifocal placoid pigmentary epitheliopathy, multiple evanescent white dot syndrome, serpiginous choroiditis, multifocal choroiditis and panuveitis, punctate inner choroidopathy, subretinal fibrosis and uveitis syndrome, acute retinal pigment epitheliitis, that is Krill's disease, acute zonal occult outer retinopathy, diffuse unilateral subacute neuroretinitis, and birdshot chorioretinopathy. Now coming one by one. APMPPE is an inflammatory retinochoroidopathy characterized by the presence of multiple placoid yellowish-white lesion over the posterior pole at the level of RPE and choriocapillaries, and the disease is mainly seen in the age group of 20 to 40 years with the mean age of presentation 26.5 years. There is no sexual predilection of this disease, that is, the disease is equally seen in males and females, and there is association of HLA-B7 in 40% of the cases, whereas HLA-DR2 is found to be positive in 56.7% cases of the patients who are having APMPPE. Delayed type 4 hypersensitivity is implicated in the pathogenesis of APMPPE and the other systemic autoimmune diseases like thyroiditis, collagen tissue disorder associated scleritis, systemic vasculitis, and erythema nodosum is found to be associated with this APMPPE. There are case reports, status post-vaccination, especially after varicella, swine flu, hepatitis B, and meningococcal C conjugate vaccine. APMPPE not closely mimics the other white dot syndromes, but it also closely mimics the non-inflammatory conditions like multifocal choriocapillary infarcts due to the hypertension, toxemia of pregnancy, and disseminated intravascular coagulation. Patients usually present with the sudden loss of vision with central or paracentral scotoma in one or both the eyes. Influenza-like prodromal illness is seen in 50% cases. The disease is usually bilateral, but sometimes what happens that the involvement of other eye takes several weeks. Mild anterior segment reaction is variably present, whereas vitritis of mild to moderate degree is seen in about 50% of cases. On fundus evaluation, what we found is multiple round, well-circumscribed, flat, yellowish-white placoid subretinal lesions at the level of RPE, which vary in size from 1 disc diameter to 2 disc diameter, and they are scattered throughout the posterior pole, extending up to the equator. Optic nerve involvement is common in the cases of APMPPE, but cystoid macular edema is not that much common. Since the disease is self-limiting, after 2 to 6 weeks, lesions resolve and they are replaced by the scattered areas of permanent depigmentation and fine to coarse clumping of pigmentary epithelium. On fundus fluorescein angiography, early hypofluorescence is noted, which is due to the blockage, and in the late phase, hyperfluorescence is present due to staining. As we can see here, that the lesion over the posterior pole, they on fundus evaluation, they are lesser in number, but as we do FFA, the number are more numerous than those what we are seeing here on the fundus. In the inactive stage of APMPPE, FFA shows fluorescence in the background area due to RPE atrophy and depigmentation. On ICG, hypofluorescence of active and healed lesions are there, and like FFA, lesions appear to be more in number on ICG than clinically seen. The disease is self-limited and spontaneous recovery is seen in most of the cases, but sometimes we need the treatment with corticosteroids, particularly where macula is maximally involved or the disease is found to be associated with CNS vasculitis. 80% of the cases achieves a visual acuity of 20/40 or more. Multiple evanescent white dot syndrome is a rare clinical entity where multiple white tiny dot-like lesions are seen over the posterior pole, and these small dot-like lesions are actually the aggregation of multiple microdots. Mutes commonly affects female, and the average age of presentation is 28 years with a range of 17 to 46 years. Like APMPPE, viral prodrome is seen in 50% cases, but anterior chamber reaction is not that common. Mild vitreous reaction is seen in 50% of the cases, along with the diffuse choroidal thickening, and when optic nerve involvement is there, afferent pupillary defect can be noted. The disease is usually unilateral, and on fundus evaluation, multiple small, tiny, round, slightly indistinct white to yellow lesions are found over the posterior pole, especially around the disc and macula. They are best appreciated by the slit lamp biomicroscopy, and uniform macular granularity is the pathognomonic of mutes. Fundus fluorescein angiography shows patchy or punctate early hyperfluorescence of white dots, giving a wreath-like configuration, and in the late phase, there is deep staining of these lesions. When optic nerve involvement is there, we can see the optic disc hyperfluorescence in the late stages. ICG is suggestive of multiple small round areas of hypofluorescent spots in early and late phases. And as in the cases of APMPPE, the lesions here in mutes are more in number on FFA and ICG than clinically seen. Fundus autofluorescence shows two types of configuration. One where we can see multiple hypoautofluorescent lesions, and the other one is multiple hyperautofluorescent lesions when we do fundus autofluorescence. Enlargement of blind spot is the most common perimetric finding apart from the central, secocentral, and arcuate scotomas. Electrophysiology is of very much importance in diagnosing mutes, ERG and early receptor potential amplitudes are often profoundly decreased, and early receptor potential regeneration time is prolonged. On EOG, prolonged latency and decreased amplitude of P100 complex is an important indicator of concomitant optic nerve dysfunction. MUTES is self-limited disease, and almost all patients regain visual acuity of 20/30 to 20/20 within 4 to 8 weeks. Serpiginous choroiditis is a bilateral, chronic, recurring, progressive retinochoroidopathy predominantly involving RPE and choriocapillaries, and this disease usually affects the age group of 30 to 60 years without any sexual genetic predilection. Patient usually presents with the blurred vision, metamorphopsia, and central or paracentral scotoma. Anterior segment evaluation is usually quiet, but in Indian subcontinent, mild non-granulomatous anterior uveitis can be seen, and mild vitritis can also be noticed in some cases. On fundus evaluation, irregular grayish-white or creamy yellow subretinal infiltrates at the level of choriocapillaries and RPE is found, and these lesions is having an affinity to be occur near the disc and then extending centripetally in a pseudopodial or serpentine manner, leading extensive chorioretinal atrophy. The active lesions are usually found at the border of the inactive lesion. Here we can see that this is the active border, and here the lesion is actually healed. And they appear in an interlocking polygonal pattern that spreads out. Amphigenous choroiditis mimics placoid lesions of APMPPE and coalesced lesions of serpiginous choroiditis, where the other presentation is persistent placoid maculopathy, which is actually a resistant form of serpiginous choroiditis and resembles macular GHPC. But persistent placoid maculopathy differs in its clinical course because this is very much prone to cause CNVM, which affects the visual prognosis very badly. Fundus autofluorescence is a very important tool in deciding that the lesion is active or it is healed. When the lesion is active, it shows hyperautofluorescence. Here you can see that this area of the lesion is active, and on the fundus autofluorescence, this is hyperautofluorescence, which is suggestive of activity of the lesion. Whereas here the lesion is healed, this border is healed, and on fundus autofluorescence, we can see that there is hypoautofluorescence. So this can be effectively used in deciding that how the lesion is behaving. As the disease is healing, lesion becomes progressively more hypoautofluorescence. Hyperautofluorescence border at the presentation becomes hypoautofluorescent, and then it disappears. On fundus fluorescein angiography, in the early phase, lesions are hypofluorescent, but in the late phase, they become hyperfluorescence due to the leakage at the border of the lesion. Healed lesions shows mottled hyperfluorescence and late staining of the scar. ICG shows hypofluorescent areas from early to late phases of the study, which is indicative of non-perfusion of the choriocapillaries. On OCT, we get active lesions in the form of hyperreflective area in the outer retina, while inner retinal layers are intact and there is no sign of retinal thickening. On perimetry, absolute scotomas are seen where lesions are active, whereas relative scotomas are noted where the disease has resolved, which corresponds precisely to the visual fundus lesions. The mainstay of the treatment of serpiginous choroiditis is systemic steroids and immunosuppressive drugs, whereas in the cases of CNVM, anti-VEGF agents are warranted. Multifocal choroiditis is an idiopathic inflammatory retinochoroiditis having prominent anterior chamber and vitreous inflammation. This disease usually affects adults in their mid-30s and is more commonly seen in females than males. The disease is having bilateral presentation with the complaints of blurred or decreased central vision, scotomas, photopsia, and ptosis. As I mentioned earlier, that there is mild to moderate non-granulomatous anterior uveitis along with vitritis in these patients. On fundus evaluation, multiple round to oval yellow-grayish lesions are noted at the level of RPE, which are present throughout the posterior pole and mid-periphery. A distinct feature of multifocal choroiditis lesion is that they are having a distinct propensity for peripapillary and nasal, mid-peripheral, and peripheral distribution. Optic disc swelling and hyperemia is seen in about 1/3 of the cases, and on fundus fluorescein angiography, hypofluorescent lesion in early phase with gradual staining and late leakage is noted. The lesions who are resolved, they show hyperfluorescence in the early phase due to the window defect, which fades in the late phase. On ICG, active lesions shows hypersenescence, whereas heal lesions shows hyposenescence. But tuberculosis, syphilis, presumed ocular histoplasmosis syndrome, DUSN, punctate outer retinal toxoplasmosis, and viral retinitis should always be ruled out apart from the other white dot syndrome entities. The cornerstone of the treatment of multifocal choroiditis is steroids and immunosuppressive agents, and if CNVM is there, we will have to treat them with the help of anti-VEGF agents. Punctate inner choroidopathy is a heterogeneous group of retinochoroidopathy, predominantly affecting young myopic females of 20 to 30-year age group. They present with the blurred vision, photopsia, scotomas, and metamorphopsia. Visual disturbance is usually seen unilaterally initially, but more commonly the lesions are seen bilaterally. Lack of anterior uveitis and vitritis is the hallmark of PIC, and apart from that, absence of CME or disc edema is not seen in the PIC patients as compared to the multifocal choroiditis or MUTES patients. The lesions are multiple, discrete, flat, yellow in color, predominantly seen at posterior pole. Sometimes localized serous retinal detachment can be seen around these lesions. These lesions evolve over few months to become either faded chorioretinal lesions or atrophic chorioretinal scars. The most significant complication of punctate inner choroidopathy is CNVM, which is seen in 17 to 40% of the cases. On fundus fluorescein angiography, we get hyperfluorescence in the early arterial phase with staining of the lesion in AV phase. Heel lesions shows hyperfluorescence due to the transmission defect. On ICG, hypofluorescent spots in early, mid, and late phase are noted, which corresponds to the area of visible lesions. Genome-wide linkage studies suggest positive association with interleukin 10 haplotype and negative association with TNF alpha haplotype similar to MFC, suggesting that PIC and multifocal choroiditis are the two spectrum of the same pathology. No treatment for the majority of the patients is required in the cases of punctate inner choroidopathy until unless the lesions are very close to fovea or there is the presence of CNVM. If CNVM is there, we will have to take care of this by the help of anti-VEGF, photodynamic therapy, and laser photopopulation. Subretinal fibrosis and uveitic syndrome is rarely seen and is usually affect young myopic females of age less than 35 years. Patient presents with mild to moderate anterior chamber and vitreous inflammation with multiple white to yellowish round discrete lesions with indistinct border with or without subretinal turbid fluid. Lesions over time fade without any retinal pigment epithelium alteration, leaving a punch out atrophy, and gradual retinal fibrosis is noted. On fundus fluorescein angiography, acute lesion shows hyperfluorescence during early phase with a mottled appearance in some instances. Late phase shows staining of the lesion with or without hyperfluorescence due to RPE hypertrophy. Abnormal ERG and EOG is noted in these patients, but the subretinal fibrosis can be seen in other inflammatory and non-inflammatory conditions like serpiginous choroiditis and onchocerciasis. These patients have poor visual prognosis despite treating them with steroids and immunomodulatory agents. Acute retinal pigment epithelitis, that is Krill's disease, is characterized by the acute inflammation of RPE cells and usually affects males more commonly than females, particularly in the age group of 2nd to 4th decades. This can be unilateral or bilateral, and patient usually presents with acute visual disturbance with unilateral blurred vision or metamorphopsia. Like PIC, anterior chamber and vitreous is white. On fundus evaluation, discrete cluster of small dark gray spots at macula are noted, and each spot is surrounded by a yellow halo-like zone. On Amsler grid testing, central metamorphopsia or scotoma are noted, and color vision in these patients are abnormal. OCT is non-specific, showing disruption of photoreceptor ISOS junction interface along with wider disruption of RPE inner band. Fundus fluorescein angiography is very unique in these patients. There is hypofluorescence of the dark gray spots with surrounding early hyperfluorescent halo that fades later. ICG is patchy hyperfluorescent in the macula in the early and mid phase. Hyperfluorescent halo with a pocket-like appearance of macula in late phase is noted and is suggestive of Krill's disease. Krill's disease is self-limiting and it resolves within 6 to 12 weeks without any treatment with good visual prognosis. Azure is characterized by the classical presenting symptoms, which include acute onset of visual loss, photopsia, scotomas, and abnormal ERG, often in the context of a perfectly normal looking fundus. The mean age of presentation is around 36 years with a female preponderance, but the disease is more common in Caucasians followed by Asians. It is associated with the antecedent illness like viral prodrome, headache, and pregnancy. As I mentioned earlier, the ocular examination is typically normal in 90% of the cases, but mild depigmentation or retinitis pigmentosa like fundus changes, which correlate very well with the zone of field loss, are reported in few cases. Enlargement of blind spot is the most common visual field defect, which can be present with central or paracentral scotomas. Fundus autofluorescence is a very good tool in detecting these lesions, and there is the presence of zone of hypoautofluorescence with well-defined boundaries, which can be hyperautofluorescent or clustered or scattered coarse granular regions of mixed hypo and hyperautofluorescence. Electrophysiology is very much helpful in diagnosing these cases. Multifocal ERG has limited role because it can detect only central lesions. That's why full field ERG is necessary for the diagnosis of Azure, but the result should be interpreted with caution to rule out other neuro-ophthalmological causes of visual loss. Azure can present as cone dysfunction or rod dysfunction. And in both the cases on ERG, there is reduction in the amplitude and delay in the implicit time of A and B or A or B wave response. In cone dysfunction of Azure, this is to the photopic white light, and in the rod dysfunction, it is to the scotopic dim blue light. VP is perfectly normal, and Arden's ratio on dark adaptometry is decreased or extinguished in all the cases of Azure, whether they are primary or they are the mixed cohort of primary or consecutive Azure. In these patients, we will have to rule out TB, syphilis, sarcoid, and viral entities. There are case reports of Azure treated with systemic steroids and antiviral, particularly with valacyclovir, but the results are uncertain, but they should be tried in the cases where vision continues to decline. Diffuse unilateral subacute neuroretinitis is an infective white dot syndrome caused by the single subretinal nematode, and this is seen mainly in children and young adults. The etiological agent of DUSN are Ophidia ascaris, Polydelphis, Traveso ascaris, and Hexametra. DUSN has two distinct stages. In the early stage, we get inflammatory signs like papillitis, multifocal chorioretinitis, and mild to moderate vitritis. Whereas in late stage, we get narrowing of the vessels, optic nerve head pallor, and focal or diffuse changes in the RPE. On fundus fluorescein angiography, we can see hypofluorescence in the early phase, followed by the late staining of the lesion, and we can even see the worm tracks. The treatment is high dose of albendazole, that is 400 milligram per day for a month, along with the steroids. And if the worm can be seen, that can be destroyed by the means of laser photoablation. Birdshot chorioretinopathy is uncommon in India. This disease typically affects middle-aged females of Northern European descent, and HLA-A29 positivity is seen in 90% of cases. The patient who are HLA-A29 positive, they have the risk factor of 15 to 250 times higher to get this birdshot chorioretinopathy in their lifetime. The disease initially involves one eye, but almost always involves the other eye with the period of time. Photophobia, photopsia, glare, and some degree of nyctalopia is noted in these patients, and there is the presence of achoid blue-yellow dysphotopsia. Mild to moderate non-granulomatous anterior uveitis is seen in all these patients, but the presence of posterior synegia and KPs are rare. Low-grade vitritis is almost always present in these patients, and on fundus evaluation, cream-colored elongated choroidal lesions with indistinct borders are seen. Their long axis is radial to the optic disc throughout the postequatorial retina. Birdshot retinopathy can also cause retinal vasculitis, predominantly affecting venules, causing CME and disc edema. On fundus fluorescein angiography, in the early phase, we can see it normal, or there may be the quenching of the vessels. Venous hyperfluorescence is noted in the late phase, and extensive late intraretinal and disc leakage is also seen. In the ICG pictures, we get hyposenescent spots and fuzzy choroidal vessels, which indicates the disease activity. On ERG, there is reduction in the amplitude and increase in the latency of the B wave. EOG is again abnormal, and elevation of dark adaptation threshold is also noted in these patients. These patients are treated with the help of steroids and immunosuppressive agents. So the crux of this entire discussion is that to diagnose a white dot syndrome is really a challenge, but this challenge can be taken care of well by the means of ancillary testing, that is by the help of fundus autofluorescence, fundus fluorescein angiography, ICG, electrophysiology, and OCT. The treatment of these syndromes actually depends upon the cause and the sequelae. I'm very much thankful to my mentors, Dr. JB sir, SKG madam, Dr. Amla George, Sudarshan sir, and Parthopratim Datta Majumdar, who taught me the nitty-gritty of uveitis. Thank you so much.
Thanks a lot, Dr. Tomar, for the excellent talk. And Dr. JV sir is here. Sir, would you like to comment first? Good evening, sir.
Good evening. Good evening. One of the thing is that, like a lot of the white dot syndrome, we call it white dots. But you know that actually serpiginous choroiditis, like we know the classic serpiginous choroiditis, that's not really a white dot. white dot should be reserved for that dots in the uveitis, like Barr-Short retinochoroidopathy, APMPP, mutes, punctatinal choroidopathy. These are the things. But when I see a geographic choroiditis, I don't like to call it as a white dot. They are not really dot. They are the geographic choroiditis. One of that white dots is you need to look for that whether it's an inflammatory or non-inflammatory etiology. That also needs to be addressed. I think it's a very nice talk. I have not listened from the beginning, but it's a very nice talk. I don't know how commonly you people see the mutes.
Sir, mutes I have seen after vaccine.
Yeah.
Just one patient.
I have seen also the few cases of mutes. These are the occurs in the young people, tiny lesions. And ICG makes it very good way to detect that mutes.
Yes. Sir, even fundus autofluorescence will give a very nice picture of mutes.
Yeah,
Because
there are two
ICG
types of-
sometimes patients don't afford. Sir, you are saying something, Dr.
Yeah,
Tomar?
and that is non-invasive also. You are not going to inject the dye. So
Yes.
fundus autofluorescence is definitely a very good tool to detect.
Yes, sir. Yes. So we'll go on to the questions. So the first question for you is, Dr. Tomar, after a viral prodrome, till what time we can expect the appearance of white dot syndromes?
Sometimes they can appear after a week or 2 weeks, but in the textbook, there's not a definitive period actually.
Yes. And do we need to perform serological testing for syphilis or tuberculosis in all the suspected cases of white dot syndromes?
No, that is not required in all the cases. Like multiple evanescent white dot syndrome or Krill's disease, if you are dealing with, that is not required. When the lesions are a little bit larger, as in the cases of multifocal choroiditis, there you need really, because they closely mimic with the lesions of TB and sarcoid.
Yes.
I agree.
Dr. Dipankar, sir, would you like to say something on this?
Yeah.
Whether we should look for TB and syphilis?
Yeah, we have to sometimes, if mutes, classically mutes with the rat-like arrangement in the macular area, having a fluorescent angiography showing early staining, then late, early hyperfluorescent, then late staining. Obviously, it's a diagnostic, fluorescent angiography diagnostic along with autofluorescence. You see rat-like configuration. So this otherwise, it's clinically sure, then unnecessary investigations are not needed. But most important thing, next 10-15 years, the concept of white dot syndrome is going to be changed. As SARS says, because the serpiginous choroiditis is a larger lesion, if you see. Now we see what we are seeing, this white dot syndrome in one axis, that is a N-phase view, either a 50 to 150 micron size lesion or say 150 to 400 micron lesion and more than 500 micron lesions. One aspect. Second aspect of white dot syndrome is going to change on the basis of depth, because OCT can pick up, you see, some are superficial, affecting RP or choriocapillaries. Some are deeper lesion. For example, PEEK is a deeper lesion. Then serpiginous choroiditis is a deeper lesion, and they tend to cause CNVM. So entire concept of on the basis of depth required a thought process of white dot syndrome. So that's very, very important. And
Yes.
for example, yes. So there, for example, there are some white dot syndrome which is a viral prodrome. For example, Dr. Tomar told that 2 to 3 weeks it's not variable prodrome is there. For example, ARP, then some peak, some mutes have a viral problem or vaccination induced thing. Second point is that myopia related. So some white dots with myopia related, peak myopia related, or ARP myopia related. So these, whether they have a correlation of finding or association with this, that has to be looked out. But I feel that concept of white dot syndrome will be looked in the future by UAS experts.
Yes, that's a very valid point that sir is trying to make, is that as we are able to image better, we know that these are all distinct, very distinct from each other. And AP and PPE was earlier believed to be a disease of the RPE, but now when we are able to image the choroid better, we know that it is a disease of the inner choroid. And similarly, PIC, as the name says, that punctate inner choroidopathy, after imaging through OCT and OCT angio, we know that it is a disease of the RPE and outer retina and not the choroid. So it is not a true choroidopathy. PIC is not a true choroidopathy. So these kind of things are coming up as there are new improvements in ocular imaging. So I think the postgraduates who are postgraduates now, and when they become UBS specialists, they will have to unlearn whatever they have learned now regarding white dots. So we'll go on to the next question. How do we manage clinically aggressive or sight-threatening cases? Dr. Tomar, how do we manage clinically aggressive cases?
If the lesions are affecting macula, at that time, since it's an inflammation and except that DUSN, all the lesions are non-infective in nature, so we will have to take care of them by the means of systemic steroids. And if recurrences are frequent, at that time we will have to start immunosuppressive agents.
Yes. So do you also treat these patients with local steroids like dexamethasone implant or posterior subtenon tricot? Do you do that? Macular
Posterior subtenon, I have given in few patients, particularly one patient who was a female. She was having serpiginous choroiditis and was pregnant at that time. I have given subtenon injection of tricot, and also have given the intravitreal tricot because oral, she was having the first trimester and she got this. So at that time I have given. Otherwise, the population here where I'm working, they are not able to afford that Ozurdex. But I think that by giving intravitreal Ozurdex, we are avoiding that systemic adverse effect of steroids.
Yes. Actually, if people can afford dexamethasone implant is a good alternative to systemic steroids, provided you have ruled out infection, because if it is an infectious uveitis, the outcomes can be disastrous. And of course, non-steroidal systemic immunosuppression is the long-term treatment for these patients, especially serpiginous choroiditis or amphigenous choroiditis, which is very aggressive, and it may involve the macula and the peripapillary retina. So these patients have to be treated very aggressively. Dr. JB sir, would you like to comment how to treat clinically aggressive or sight-threatening cases?
Ma'am, we'll have to repeat the question for sir.
Yes, Dr. JB sir, I want to ask you, how would you manage a clinically aggressive or sight-threatening cases?
Of choroiditis.
Conference. JB?
Yes, sir. Ma'am, we can move on to the next question.
Yeah, sure. So I think there's some disturbance. What is the role of Ozurdex implant in serpiginous choroiditis? Dr. Dipankar, sir, do you have any experience on Ozurdex in serpiginous
No,
choroiditis?
if serpiginous choroiditis, after the treatment or ongoing treatment, if there's a CNVM, then no, we can obviously give a Ozurdex injection intravitreally. But important thing is that all the immunosuppressive that is going on should be there. Okay, either a MMF or a Azoran or a triple therapy, whatever immunosuppressive are, that should be on. And additionally, if there is a CNVM, Ozurdex can be given.
Okay. How to manage a case of PIC with submacular involvement? Dr. Tomar, how do you manage a case of PIC with submacular involvement?
As I mentioned earlier, that if macula is threatened, we will have to treat this inflammation by the means of steroids. And if CNVM is there, because PIC, 17 to 40% patients we see, they develop CNVM. That is the worst complication of PIC in these patients. So if CNVM is there, we will have to go ahead with anti-VEGF agents.
Yes, and PIC and multifocal choroiditis have a very high propensity to get CNVMs, and these CNVMs are sometimes we are not able to diagnose on fluorescein angiography because on fluorescein even the CNVM may leak, and you don't know whether it is reactivation of the inflammation or there is an underlying CNVM, because both will appear like a bright spot. So Octa has really changed the diagnosis of inflammatory CNVMs in these cases, where you can clearly see the network in the outer retina. So if you have Octa in your practice, you can really diagnose inflammatory CNVMs very early in these cases. And sometimes patients do not even have a loss of best corrected vision. The Octa picks up these networks that early. So before the patient gets exudation or decrease in vision, you are able to diagnose these cases. So we'll move on to the next question. What are the diagnostic characteristics of Krill's disease?
When you evaluate the fundus,
pigment epithelialitis.
Yeah, in the Krill's disease, what we see that these lesions are very tiny. They are dark gray and they are surrounded by a yellowish halo. And if you will do fundus fluorescein angiography, in majority of the choroiditic lesion, we see early hypo, late hyper. But if we will go ahead with this fundus fluorescein angiography, that PIC and mutes, they have typical characteristic features. So in the patients of Krill's disease, when we do angiography, in the early phase, we will see that there is hypofluorescence where the dark gray spot is there. And that halo actually shows hyperfluorescence. And this hyperfluorescence in the late stage fades away. So by the help of this FFA, we can easily diagnose that this is a case of Krill's disease.
Okay, thank you, sir. And I think we are done with all the questions. Dr. Dipankar, sir, would you like to add any comments on white dot syndromes in general?
Okay, for students, one important thing is that in active white dot syndrome, in FFA, all lesions are early hypo, late hyper, except two conditions. One is PIC and other is mutes, where you get early hyper and late staining. So this way, if you know this point, you can create the entire chart out of it, of all white dot syndrome. And for ICG, all active lesion is hypofluorescence. Got the point?
Yes, this is a very important point and very important for postgraduates to note this down, because when you know that these are the only two conditions where the FFA findings are atypical, and it will really help in the OSCE. So that's a very good point that sir has made.
Dipankar sir, I'm having one question for you. how will you suspect azure? Because in majority of the patient, fundus is typically appears normal, and the vision is deteriorated. On the basis of only fields, we cannot say anything.
So, okay, you're asking this question to me?
Though Deepankar sir.
Azure, you see the zones of involvement is differs. Okay, the zones of typical zones of involvement. There's 3 pattern that has been described. I think that pattern, if you can well established or well seen, then you can diagnose azure. But azure cases are very less, not so common in India that we see too much azure cases.
Yes. So one case I have seen in my practice, azure, like sir rightly pointed out, that there is a trizonal involvement, and that is seen in fundus autofluorescence as well as OCT. So zone 1 is normal retina, zone 2 is speckled hyper autofluorescence, and zone 3, where there is total loss of the outer retinal layers, there you see complete hypo autofluorescence. The same thing you can see on OCT. So zone 1, you can see all the retinal layers, that is a normal retina. Then the lesions are around the disc. So generally around the disc. And then you go to zone 2, where you will see some loss of outer retinal layers, and zone 3, where there is complete loss on OCT. So this trizonal involvement in azure is very typical. So once you see that case, you'll always remember throughout your life. It's like that. It's that typical. Yes, and these patients. Yeah, the subfoveal outer retina is just spared in these patients, and that's why their vision is reasonably good. Like my patient, I've been seeing him for the last 5 years. He keeps coming for follow-up. So the best corrected is 618. So azure should be diagnosed on the basis of fundus autofluorescence and not just on FFA or fields. So fundus autofluorescence is very typical in these cases. So I think
Yes, Abhilasha.
yes,
Very good.
so I think we have completed all the questions today.
And there is one more question, ma'am.
Okay.
When and how to shift on immunomodulators, ma'am?
Yes, yes, this is a very important question. Treatment protocol, when to start steroids, how to taper, and how to shift to steroid sparing immunomodulatory treatment.
So when the lesions are actually threatening the macula, they are vision threatening actually. At that time, we will have to start steroids, and the tapering of the steroids actually depends upon the response of the lesion. If it is responding, we will taper off it rapidly. And the other question is that when to start immunomodulatory agents. If the disease is not responding to the steroids, or as soon as you are tapering, the disease is coming back, or the patient is having dependency on steroids, or the patient is feeling adverse effect of steroids, at that time we will have to switch over the patient to immunomodulatory agents.
Sir, would you like to add, Dr. Deepankar, sir?
Yeah, if the macula is threatened by a macular serpiginous choroiditis or amphigenous choroiditis, I will obviously, if the patient comes for the first time, IV methylprednisolone would be the right choice to start with. Then we'll shift to the oral steroid after 3 days, 1 milligram per kg body weight. Then at the same time, in those aggressive cases, we'll either put Azoran or MMF on those cases. Sometimes, in spite of this treatment, you may not be in a position to control activity. It is again progressive in some situation where additional cyclosporine other is added, particularly for serpiginous variety of choroiditis, which is very aggressive. So there may be 2 drugs therapy, there may be triple therapy as described in the literature and other things.
Thank you, sir. Actually, for the postgraduate students, if you read the book, The Diagnosis and Treatment of Uveitis by Dr. Stephen Foster, so he has very well described how to start and how to taper. As Dr. Dipankar sir said, that we have to start at 1 milligram per kg body weight, but as we go down, we need the hypothalamo-pituitary axis to recover. So as we taper, we should taper slowly. So below 40 milligram, we should go 5 milligram per kg each week. So when you are bringing the dose down, so from 40, bring to 35, don't go directly to 30. And when you are going below 15, then decrease by 2.5, 2.5, and then below that, you have to go even more slowly, like 2.5 for 2 weeks. So that is how you should decrease. Like initially, you can decrease by 10 milligrams. So say 60 1 week, then 50 1 week, then 40 1 week, then 35, 30, 25, like that. So when you are going down, go really slow so that the body gets time to recover, because our body itself is making steroids like 7.5 milligram per day. So when we are taking external steroids, the body's own production of steroids goes down. So when you need the body to recover. And regarding when to start systemic immunosuppression, it is some diseases are very aggressive, like VKH. There are many papers which say that we should start these drugs at the initial presentation along with steroids, because they take about 4 to 6 weeks to start acting. So by the time their action starts, steroids can take over, and later on you can continue with the whatever drug of choice you have taken for the particular disease. So when to start, it typically depends on the disease type. Some diseases, as sir pointed out, are very aggressive and they need to be treated with intravenous methylpred, and later on you can start triple therapy also wherever required.
One thing should
Only
be very
thing,
much clear in
Abhilasha,
the
only thing is, Abhilasha, we should not be in a idea that 1 week tapering, 10 days tapering. This is actually, if you, for the expert, it is very important that the response of the treatment, initial treatment, how it is responding. On the basis of that, only you will taper. In VKH, if you taper by say 2 months, 10, 10, 10, 10, or 1 week, 10 milligram reduction, it will not, because you have to continue for a significant months of treatment. Okay, so that point is very, very important. Don't be in the idea that 1 week, 10 days will be for the steroid tapering. I think for the expert, that is very important.
Yes, sir, exactly. Actually, probably I did not put it in a proper way. This is just a guideline that they have given. And of course, the tapering should depend on the response to treatment. And many times you have to continue 10 mg for a long time.
And Dr. Abhilasha, one thing I would like to add, that in the cases of VKH and sympathetic ophthalmitis, after that IV methylprednisolone infusion, we should start at the dose of 1.5 milligram per kilogram body weight per day. And one more thing regarding these postgraduate students, that immunomodulatory drugs are not steroid-sparing drugs actually, particularly in the cases of Wegener's disease or in the cases of microscopic cholangitis. They are the first-line drugs. You will have to start them because Wegener's disease is a very nasty disease, and if you haven't put your patient on cyclophosphamide, you are in a trouble. So you will have to decide that what is the etiology behind this inflammation. First, you will have to decide that whether this is infective or this is non-infective. If it is non-infective, then only you will have to plan for immunosuppressive agents. And before starting these immunosuppressive agents, you will have to rule out any hidden infection in the body. And that holds true for the steroids. Because if your patient is having some hidden infection like pneumonitis, bacterial pneumonitis, at that time you will have to take care of this infection and you will have to start antibacterial cover.
Yes, those are some important points. Just one thing, that 1.5 milligram per kg increases the risk of avascular necrosis of the femur. So anything above 1 milligram per kg body weight will increase the risk of avascular necrosis of the femur. That is a
That
very
is always
serious,
tricky.
yes, that's a very serious complication of oral
Yeah.
steroids,
But
and
that
it should be
PTH
kept.
and SO, they are side threatening, particularly SO. SO is dangerous.
And
So,
aseptic femoral necrosis, sometimes it's when the dose is high, sometimes when dose is prolonged also. So
yes.
that can cause, bone scan, bone densitometry, these are very, very important when you follow the patient of uveitis with steroids and other medications.
We will have to decide the dose on the loss and benefit, actually.
So we had a very good discussion today. Thank you so much, Dr. Dipankar sir, and thank you, Dr. Tomar, for your time and effort in making the presentation on white dot syndrome. I'm sure the postgraduates will benefit from your talk. And with that, we'll go on to Dr. Rolika.
Yes, ma'am. Thank you so much. And I would love to thank all the postgraduates who were there physically for iFocus. You've had a very tiring and yet very productive 1 week of iFocus offline. And after 2 years, we were physically present and several sessions were conducted. I'm glad you all came, and the ones who could not come offline, all the sessions are available right now, and you can access them on YouTube live sessions as well. So I don't know till when are they available, but try to get the most out of it. Thank you, Thomas sir, Dipankar sir, and Abhilasha ma'am for your precious time and excellent discussion. And our next session will be on March 10th. That would be corticosteroids in uveitis, when, what, and how, by Dr. Manisha Agarwal, ma'am. So looking forward to having you all over here on Friday. Thank you.
Thank you, Rolika. Thank you, Abhilasha. Thank you, Dr.